Good morning. This is Shelley Rodriguez with the California Academy of Family Physicians. Thrilled to bring to you today Venous Thromboembolism Beat the Clot, featuring Dr. Mark Dressner. Dr. Dressner is a family physician practicing with the Permanente Medical Group in Southern California and a member of the master faculty for this project. Mark is a past president of the California Academy of Family Physicians and actively engaged in education at all levels, from medical student and resident to practicing family physicians. This session today was recorded for your benefit. It's available at familydocs.org, CME, online activities. At the end of the activity, you'll get a link, and on that link, you can do your evaluation and your request for CME credit. This activity will be approved for 1 prescribed CME credit. And with that, I'm going to hand it over to Dr. Dressner, who's going to take you through VTE, Beat the Clot.
Hello, everybody. This is Dr. Mark Dressner here, and I'm very happy to be talking with you today about venous thromboembolism, a very important topic always, but even more important with some of the newer medications out now for anticoagulation that we need to become very familiar with. To start off, this is the faculty for our project. We've been working together for a few years in putting together curriculum and going around the country speaking to medical professionals about anticoagulation. One of the most exciting things is on the left is David Garcia, who's a guru for on the topic of anticoagulation, specialist in the area, and is one of the people often included in the policy making and so on of what we should do in anticoagulation. And I have his email at my fingertips, and whenever I'm stuck in any area or want to discuss something, I have him to talk with. And this is me, and Shelley's already made an introduction, so we can go to the next slide. And to let you know, this is an activity sponsored by the California Academy of Family Physicians, and it's an initiative supported by an unrestricted educational grant from Bristol Myers Squibb and Pfizer. And from my heart, I have to say, of all the medications that are out now, I do not know which ones with which pharmaceutical company. And so truly, I am unbiased on this as far as the medications go. Now, one of the other things we have available to you is an ME website, and this ME website has education for your patients. So if your patient has DVT or a PE, you can go to this website and your patient can click on it and they can learn in an appropriate manner all about VTE and the treatment for VTE. So along with your teaching, you can send your patients to this website and they can get a lot from that. So why are we talking about this topic? We surveyed many family physicians and others about what their needs are in this area, and I'm not going to go through and read this slide. You can look at it, but certainly there is a lot of questions on how to deal with patients in diagnosing and treating venous thromboembolism. So we've surveyed, and the need is there. The main topics we're going to talk about today, or the questions we're going to answer, is number 1, how do I complete the initial assessment and management? How long do I treat? And 3, what about perioperative and periprocedural care? So this will be our main focus for today. At the end of this talk, and I think it's really important to always state the objectives, at the end of this talk, you should be able to define the short-term and long-term goals of anticoagulation for VTE, determine the optimal length of therapy based on clinical factors, and manage anticoagulation around medical procedures and special situations. So let's start with the initial assessment and management. I want to say that most of what we're talking about today comes from guidelines that were published in February 2012 supplement of CHEST, and also an update that was published earlier, late in 2012 and earlier in late in 2015 and earlier in 2016. So there's the extensive recommendations from 2012 and an update of some of them from early in 2016. In order to discuss the topic, we're going to present a case, and throughout the whole hour, we'll be coming back to this case and adding things onto it in order to make this very realistic. So the first case we're going to discuss is Claire. Claire is a 49-year-old woman. She developed a unilateral leg pain and swelling 4 days after completing a 10.5-hour air flight. Her heart rate is 104 and her blood pressure is normal. Arterial oxygen saturation is 91% on Rumera by pulse ox. Okay, so the first thing we have to look at is, how do you approach this case? How do you approach it from a diagnostic point of view, and how do you approach it from a treatment point of view? And a lot has to do with what is your pre-test probability of what is happening with her. So when you look at this case, your first thought immediately is she has a DVT. Now, your management is going to depend, do you think this is a high probability, moderate probability, or just a low probability that she has a DVT? Now, grossly, in this case, you look at the history, and there's almost no question in your mind that she indeed has a DVT, if not also a PE. That may be more questionable, but she almost certainly has a DVT. Okay, there's no question grossly. And in the case, so there's two ways to approach this. One is that, yes, she has a DVT, prove to me that she doesn't have a DVT. But if this was a little bit more unclear, then you would need to look at other ways to figure out what her probability is. So one of those ways would be using the Wells criteria. And by using the Wells criteria, you can look at different aspects of the patient's history, and then from there, plug in the numbers and decide where she fits as far as high, moderate, and low probability, if you were on the fence. In this case, I would say you're really not on the fence, and the chance of her having a probability is pretty high. If you decided you did want to use the Wells criteria as well, and you looked through the different numbers here, you would also find out that she is high probability for having a DVT. Now, without changing the slide, if you have someone who's a high probability for DVT, you need to really start treatment as your first line. You don't want to be going around trying to diagnose her in a manner that may take longer than you would like when you're almost certain what her diagnosis is. So if you have a high probability patient, you really want to start treatment or start arranging for that treatment while you are then getting your diagnostic tests. Now, if she was moderate probability, then you have a little bit of leeway there. You think she has a DVT, but you're not really sure. So you really want to make your diagnosis first before you start treatment. But you don't want to wait too long with that. So the guidelines say that within 4 hours, you should be able to get your definitive test to decide if she has a DVT or PE. And if you actually cannot get that test done and get the results to you, you might consider treatment in her even before you get the results if you cannot get it in a timely manner. If she was low probability, let's say that she ran in a 5K over the weekend, comes in to see you a few days later, has pain in her calf, and you're thinking, well, it's probably muscular, she just ran a 5K, but there's a slight suspicion that she could have something else going on. You certainly should not start treating, but you need to order your diagnostic tests, and they should be done in a somewhat rapid manner. And what the guidelines say is it should be done within 24 hours. And if you don't have the test done and the results to you within 24 hours, you should consider treatment. So that is why it's really important to put somebody in a category, high probability, moderate probability, low probability, to decide your next step in treating the patient. Using something like the Wells criteria is very useful for, I think, moderate or low probability patients, but someone who grossly seems to have a DVT in this case, you may or may not use a criteria like that because your clinical assessment is so important. So our first question in looking at Claire would be, the most important next step in the management of this patient is measure her D-dimer concentration, perform a CT angiogram, administer anticoagulation, administer systemic thrombolysis, or perform pharmacomechanical thrombolysis. Okay, and even before looking at this question, I went through how you should think about it in order to get the correct answer here. And in this case, make your selection, but the correct answer really would be C. You want to administer anticoagulation even before a test because your pretest likelihood is so high in this patient. Clearly for a DVT, grayish on PE. Okay, which of the following would not be an indication for treatment over and above anticoagulation? So which of these would not require more than just anticoagulation, which means 3 of these would require more intensive treatment. So A, pulmonary embolism with systemic hypotension and tachycardia, but normal arterial oxygen saturation. B, iliac vein thrombosis, possibly comprised circulation. I will not pronounce phlegmasia ceruleus dolens because it is hard to say, but I just pronounced it. Common femoral vein thrombosis greater than 6 centimeters in length. Or D, pulmonary embolism with biochemical and echocardiographic evidence of right ventricular strain. So which of these would not require more than anticoagulation? So make your pick, and we'll be talking about that in a few minutes. If you've never seen it before, this is a picture of phlegmasia ceruleus dolens. Now you know what it looks like. I've never seen it, but it's something you always need to be out on the lookout for in someone with a DVT. Now, before we go to the next slide, I want to talk a little bit about D-dimer, because on the first question, one of your options was, should you get a D-dimer? And D-dimers are useful if they're negative. But there are so many conditions where a D-dimer can be positive. D-dimers can be positive if you have malignancy, if you're older, if you have an infection, if you're pregnant. If you've just had surgery or trauma, you can have a high D-dimer. If you have any kind of inflammatory condition, if you've been are an AFib or you've had strokes, all of these conditions can make your D-dimer go up. So because a D-dimer is very sensitive but not very specific, you need to be very careful when you order that D-dimer. And I think we've all had that situation where a patient's presented to the emergency room and then they're sent back to us, and maybe they do not have a DVT or PE, but we're stuck with the patient does have a high D-dimer, and we kind of have to explain that away somehow. So in somebody who has a low pretest probability of a PE or a DVT, a D-dimer might be helpful, because if it's negative, then you're done. You don't have to do any other workup, and they do not have a DVT or a PE. Of course, you have to look, do they have any of these other conditions, because you don't want that positive D-dimer that has nothing to do with the clot. Now, if they are a moderate probability patient, then you have to kind of weigh, should you get the D-dimer? Should you just go to the ultrasound? And if you get the D-dimer by itself and it's a little bit high, you have to get the ultrasound anyway. So that's kind of a plus minus. You might just go directly to ultrasound. You might order both. And certainly if it's the pretest probability is high, you'll go right to the definitive test of an ultrasound looking for a DVT. So remember, put D-dimers in the proper context, and I would use them mainly if it's low probability, because then if it's negative, your workup is done. Moderate probability, if it's negative, your workup is done as well. But if it's high and you have a moderate, if you're thinking that there's a moderate probability, you're going to have to go on and do further testing. As a little bit of a side, a little bit of a segue to another area is what happens when you get a distal DVT. And so often we get these, and you don't automatically treat a distal DVT. You have to look at other signs and symptoms with that distal DVT to decide if you would give that patient anticoagulation. So would you treat a distal DVT? Yes, if it's very, very symptomatic, if it starts extending, and that extension could be whether it extends even more distally, as well as extending to the proximal veins. Or if you do serial imaging, you get a ultrasound, and then 2 weeks later get a second ultrasound and you see the extension, then you should treat. And also if they have any of these other risk factors. So if you've got a positive D-dimer and you have the distal ultrasound, it is recommended to treat as if it was a proximal DVT. The size also will, the size or the number of veins involved would get you to treat. If it's very close to the proximal veins, it will most likely extend and you should treat. If it's unprovoked, if you have no reason for a person having a DVT, you would strongly consider treating a distal. If they have cancer or history of a DVT, or they're an inpatient, these are all reasons to treat a distal DVT. So you'd have to tease it out a little bit with those distal DVTs because you don't treat them all, but with these risk factors or with serial imaging, you might go ahead and treat. So we have different options for treating a DVT, and these are all listed here. We're going to talk about some of them. So what about umbrellas, inferior cava filters? Those are really falling out of favor. Those should only really be used if the patient is at such a high risk for anticoagulants, you really have no other choice in treating for the clot. This slide shows you what happens if patients are given both anticoagulation and a clot, anticoagulation and an umbrella, and actually a lot of the outcomes are worse when that umbrella is actually there. So you really want to avoid putting the umbrellas in. Also, when you put an umbrella in, it should be one that can be taken out again when the patient is no longer at danger for anticoagulants. Probably the most frequent thing that happens with these retrievable filters is that they are left in. They're put in one place, and they go to another place to get their follow-up care, and then the filter never gets removed, and you don't want that situation to take place. So the main emphasis is here. Is do not use the filters unless there's really a very strong contraindication for anticoagulants, and you want to take that filter out once the patient can be on anticoagulants again. Now, what are acceptable indications for doing more than anticoagulation? Okay, so here, going back to the last slide, let's talk a little bit about when do you actually need more than just anticoagulation in a patient. Now, first would be hypotension. If the patient has a PE and they're hypotensive, defined as a blood pressure less than 90, then you definitely want to go in there and do something about the clot. They need much more than anticoagulation. Or if they're deteriorating, if their O2 is okay and their blood pressure is okay, but they're starting to trend down, before they get to that point where they're hypotensive or they're hypoxic, you want to do more about the clot, so you would want to go in and try to lyse it. And they would most likely need more supportive care. A little bit controversial would be if there's evidence of RV strain, and that would be on EKG, or you got an echocardiogram, or if you got troponin and your troponin's a little bit high because there's such strain on the heart that you're getting a little bit of release of troponin from the heart muscle, this may be another reason for doing thrombolysis. This is a little bit of a gray area, but you should really strongly consider it. If you have a DVT, you might look at thrombolysis if you have compromise of the tissue, as we showed in the previous photo. The size of the clot itself, or the size of the DVT itself, is not a reason for using more than just anticoagulation. But these are really kind of the strict guidelines, particularly the hypotension or the trend towards hypotension, that would want you to give more supportive care and thrombolysis. So all this information that we've given you, does this change your treatment of Claire? She has a diagnosis of VTE grossly, and we actually have gotten an ultrasound, and does indeed show a DVT. Is Claire at risk for complications of a pulmonary embolism? Can she be treated out of the hospital? And would you assign her high or low risk? Just a little bit about terminology here. When we talk about treating someone for a DVT, the initial treatment for the acute period, acute or initial treatment, is considered 0 to 7 days. When you talk about long-term treatment, long-term actually says up to 3 months. So long-term treatment is 7 days to 3 months, and extended therapy for treatment with anticoagulation is anything above 3 months to an indefinite treatment. So if you hear me using those terms, long-term means 3 months and extended is more than 3 months. Now, one of the controversies on this patient is, does she have a PE as well? She has slightly higher pulse than normal. She has a lower end of normal O2. And doesn't matter, should you also get a CT angio to look for PE when you've already documented that she has a DVT and ultrasound? And I think we can discuss that because the treatment is not going to change at all. The treatment is the same for a DVT and a PE as far as anticoagulation goes. And giving her a CT with a dye load may not be the thing that you want to do at this time, given that you're a little bit on the fence of whether she has a PE or not, but you know that indeed she has a clot. A little bit of another segue, things are not always clear, just like that distal DVT. Sometimes we're not even sure if she has a PE despite, a patient has a PE despite the imaging. Often a patient will get a chest CT for another reason, and incidentally, there's a subsegmental PE suggested. And since you had no inkling that this patient could possibly have a PE, what do you do with a CAT scan that shows a subsegmental PE? Is it true? Is it not true? Do you treat? And I think it's worth a little bit of time talking about things that would make you treat or not treat. So you need to look at the quality of the CT. Was it a high quality CT? Are there multiple intraluminal defects, meaning it's just not one area, but many little areas that would be more suggestive of a true PE? Is it a more proximal subsegmental artery? Those are easier to see. That would make it more likely to be a true PE. Are the defects that you see are more than one image, or is it just one image and all the rest of the images are clear? If it's more than one image, it's more likely to be a true clot than not. And also, can you see it on more than one projection? And is the PE, is it surrounded by contrast? Is the finding surrounded by contrast, or is it actually adhered? That will point you in one way or the other. Is the patient actually symptomatic, or is this an incidental finding? And often these are incidental findings. The patient is not, has no chest pain, their pulse is not up, their oxygen is not down. So you need to look at that. What is your pre-test probability of them having a PE, even to begin with? And then is the D-dimer high? So these are things to look at if someone has a subsegmental PE, where do they fit in here, and then decide whether you treat or not. Because often what you see on the CAT scan does not really represent a pulmonary embolism or a clinically significant at all pulmonary embolism. Okay, so you want to decide what is her risk with a PE of the PE turning bad. And this really is going to get us into the topic of, can we actually treat her at home even though she has a PE? So what you want to use, and I think in this case it's very important to use a scale like this because you're considering sending someone with a PE home. And many of us would feel uncomfortable with that despite the data that shows we can feel otherwise. So this is a really good assessment scale called the Pulmonary Embolism Severity Index, the PESI score. It's very easy to use. And a lot of these scales you can actually just pull up on apps on your cell phone and plug all the numbers in there. So if we look at this scale and we actually plug our current patient in, I'm not going to go through each point, but she would come out with a low, she would be a PESI class 1, which would make her chance of death over the next 30 days very, very low. And we can most likely safely treat her at home with a PE. So you have this slide, you have the scale here, and you have what happens. If you're a PESI 5, your chance of dying over the next month is almost a 25% chance of death over the next month. You want to really look very closely at sending that patient home. So really, if you're PESI 1 or 2, you should strongly consider, if there's no other contraindication, of treating that patient home with a PE. But this is a very good assessment tool, and I would really use it if you're thinking of sending a patient home or sending them home very shortly after hospital admission. Now, when you're trying to decide what to do with a patient with a PE, and especially if you're trying to decide if you're going to send them home, it's a balance between the danger of a PE and the danger of your treatment. What is the risk that the patient is going to actually bleed from your treatment? And there's this scale called HAS-BLED, And you can plug all the numbers in here and come up with a score. And it tells you what's your risk of bleeding. So you may want to do this as well, because if the risk of bleeding because your treatment is really high, then even if the risk of the clot is low, but the risk of bleeding is high, you might want to reconsider treating the patient at home. You might want to watch them a little bit before you would send them home. So remember, it's always a balance between what is the risk of the PE and what's the risk of your therapy for the PE, the anticoagulation. So low-risk PE really can be treated out of the hospital. Now, this shows you the 90-day event rate of PEs of patients who were low risk for PE. And as you can see, the fatality actually is really quite low, 0.47. The risk of a major bleed is quite low. This data, just looking at this slide, is enough, I think, to give you comfort that in the right situation, you don't have to necessarily admit a patient and keep them in the hospital a few days to treat your PE. So what are things you should look at in determining can the patient actually go home? So number one, look at the PESI score, and if it's low, this is when you consider it. If they have a high PESI score, you're not even going to consider it. So going through the list, are they hypoxic? And in this case, she's not hypoxic. 91% would not be considered hypoxia. Is the blood pressure less than 100? And in her case, it would not be less than 100. Has she had any recent bleeding? Does she have severe chest pain? Are the platelets low, so you could get into trouble there? Has the patient had a PE already on anticoagulation? And does the patient have severe liver or kidney disease? Go through these bullet points, and if they don't have any of these, you start thinking, you know, I really can treat this patient at home. You also have to look at some of the other issues that we listed on the right. Do they have support at home? Is there someone who will be there with them so if something can happen, we can call 911 right away, we can get them to the hospital right away? Are they living in the country without ready access to medical care? Do they have phone access to medical care? Are their living conditions appropriate that they will not get into trouble being at home? Do they have a place they can store their medications? Do they actually have a home? Is the patient going to be compliant with follow-up? Are they going to be taking their medications on a regular basis? Are they going to be coming in for blood tests? Are they going to be missing doses of their medications? And are they going to be following up promptly? The other thing to look at is that, are they well enough to go home? Do they have other health issues that sending them home, they're going to fail treatment because they're struggling with their other health issue as well? So we're not just looking at pure medical issues, we're looking at psychosocial issues that also come into play. And if you've gone through all these bullet points and then you feel comfortable, you certainly can send a patient home to treat with a PE. So in our current patient, is anticoagulation sufficient, yes or no? Well, we've gone through, we've looked at her, we looked at the different scores, and we can say that anticoagulation certainly is enough. She's having none of the bullet points that will make her worry that she needs thrombolysis or supportive care. Can you treat her out of the hospital? With or without proving that she has a PE, let's assume clinically she has a PE based on the soft call of a slightly high pulse. That could be due to just anxiety of the situation itself and the lower end of normal O2. Let's say just clinically we think she has a PE. If we go through and plug in her PESI score and look at other areas that we've just gone through, she really doesn't score high in any of those. So we really can send her home with anticoagulation, PE or no PE, given her low risk. So then the question is, what are we going to treat her with? So the following treatments for acute DVT PE, which does not require an antecedent course of heparin. So you can see the answers there: dabigatran, rivaroxaban, edoxaban, warfarin. This is one of those questions where you just have to have memorized the medication and know which of them can you start from scratch without heparin and which of them can you start with heparin. Now I must say, why is it that some of the newer anticoagulants need heparin beforehand and some don't? It really boils down to how the studies were done. The studies were done comparing the medications to heparin, warfarin, and some of the studies used the medication by giving heparin first, followed by the new anticoagulant, And some of the studies were done without giving heparin first, just giving the anticoagulant from scratch. And that is why this recommendation is there, and that's why the FDA indication is there. So it's really just how the studies were done. Nothing really magical about the medications. Just want to make that clear, although you certainly want to stick with what's recommended. So our traditional approach to treating patients for a DVT was to use low molecular weight heparin. You do that for 5 to 7 days. You start warfarin on day 1, and then you need the overlap until your INR is between 2 and 3, and then you can stop the low weight molecular heparin, and then the patient needs to follow up regularly for their INRs. Just a note about warfarin. Really starting at 5 milligrams a day makes a lot of sense. You're not going to get to the goal of an INR between 2 and 3 any faster by using 10 milligrams. What most likely will happen when you get to day 5 is you've overshot the INR. It's going to be greater than 3 if you use too high a dose of warfarin. So I recommend starting with 5 milligrams a day, and then depending on where you are around day 5, then you can make some adjustments. But starting at 10, you're almost for sure going to overshoot your INR goal. Okay, so that's our traditional treatment. We do have newer options, and here are our newer options. There are 4 novel or new oral anticoagulants, which is what NOAC stands for. There's many terminologies, but the most common is NOACs, and that's what we are using. And as you can see, they differ by, can they be BID, can they be QD, rivaroxaban and apixaban are the 2 that can be used without starting heparin. The challenge, of course, is these are expensive medications, and you need to arrange with the health plan to get these medications, and that could be almost more challenging than getting the heparin to begin with. But those 2 can be started without heparin, whereas dabigatran and edoxaban, you do need that heparin prior. And again, that's just because what the studies have shown. So what would be reasons not to use the newer oral anticoagulants? They're all renally excreted, and with severe renal insufficiency, you would want to avoid them and go towards the more traditional treatment with warfarin, which is not renally excreted. At the extremes of weight, greater than 120 kilograms and less than 50 kilograms, you don't want to use these medications. This is mainly because the studies have not been done with these weight ranges. And anecdotally, as I've given talks about anticoagulation around the country, most people have talked to me after the talk have said that their treatment failures have been when the newer anticoagulants are used in obese patients when they shouldn't have been, and then they wound up having another DVT or another PE or extension of their DVT. So certainly look at the weight of the patient, and you should not be using them. If you're thinking of using TPA, you don't want to use them. You want to have the person on heparin so you could stop it right away and then do the TPA. Certainly, if the patient can't afford the medication, you shouldn't be using them, because if they're not compliant, you're going to get into issues. It used to be said that there was no reversal agent for these medications, but there's newer info, and we'll talk about that in a second. And if they have a known prothrombotic state, so they have cancer, they have antiphospholipid syndrome, you probably shouldn't use them. And that's because really the studies haven't done. We don't know if they work or not. They might, but we don't have any data on that yet. So during the middle of doing these talks in the fall, Praxbine came out, and that is our reversal agent for Pradaxa. And if the patient is bleeding and needs reversal, you can give this and you get almost immediate reversal. This is, it totally blocks the action of the Pradaxa, and you get immediate reversal right away. And now there's on fast track approval another reversal agent that's coming close to being on the market. So one of the big fears when these medications first came out is if the patient bleeds, we're not going to be able to reverse them. And indeed, that is beginning to change now, at least specifically with Pradaxa, you can get a reversal agent. I must say, though, that when somebody's bleeding and they're on an anticoagulant, it isn't always because of the anticoagulant that they're bleeding. You still need to look for what is actually bleeding and deal for that entity that's bleeding, that's just bleeding more because of the anticoagulant. It isn't the anticoagulant itself that's causing the bleeding. It's the ulcer or the polyp or the AVM or whatever it is that's bleeding that needs to be taken care of as well. It just is bleeding more because of the anticoagulant. So there's really several approaches to someone who's bleeding with an anticoagulant, and only one of those is reversing the anticoagulant agent. So just going back to warfarin for a minute, going back to some of the challenges with warfarin, unlike some of the newer indications, there's a delayed onset and offset, meaning it does take 5 days because of the half-life of the factors that warfarin affects. And if you're taking someone off warfarin, it takes about 5 days in order to have their coagulation go back to normal. There's an unpredictable dose response, but at least you do have that range of the 2 to 3 to go to. Just to digress for a second, when we talk about someone who's obese, going back and using warfarin instead of the newer agents, you still have that target goal of 2 to 3. So you're not just giving an agent where you don't know what's going on in someone who's obese. You actually still have that target of 2 to 3. So in the obese, certainly using warfarin makes sense. There's the narrow therapeutic range. It has to be between 2 and 3. And most of the complications with warfarin do actually happen when you're not in that range. So a lot of the bleeds with warfarin aren't because of warfarin itself. It's when warfarin has an INR between higher than 3. As we all know, there's many drug-drug interactions, drug-food interactions. You do have to bring the patient in for monitoring. But I must say the new guidelines say that if your patient has a stable INR consistently on warfarin, you actually don't have to check even every month. You can start spreading that out to every 3 months as long as they've totally been stable with their INR. And though warfarin is reversible, it has a slower reversibility than what we have now available for the newer agents. A little bit more data on the newer agents. So what should we highlight on this slide? First, to know that dabigatran is a thrombin inhibitor, whereas the other 3 are factor Xa inhibitors. And that may come relevant if you need to do testing, some unusual testing in the future. Also, looking at the half-life is really important. The half-life of warfarin is 40 hours, where the half-life of the other agents are much, much shorter. Also looking at the administration, some of the newer agents are twice daily, and we're talking about an agent with short half-lives. So if you miss even one dose, your risk of extending a clot or having another clot increases. A twice daily medication could be an issue because of the greater likelihood of missing a dose. So 2 of the agents are twice a day, 2 of the agents are once a day. The big issue is renal excretion. As you look, dabigatran has a 80% renal excreted, the other ones less so, but still a high percentage of renal excretion. If you had to choose one and there was kidney problems, we would probably go with apixaban, which has the least amount of renal excretion. Okay, this just summarized really everything that we've said about warfarin and the newer anticoagulants in the last few slides. Just one digression just about cost. Always remember that warfarin, generic warfarin, is about $5 a month, and the newer agents cost between $250 and $300 a month. That's a huge cost differential, even when you include testing an INR with the cost issue, and that may be a determining factor in what you use in a patient. The newer guidelines that came out earlier in 2016 now makes the recommendation that we should be using NOACs from the start and be moving away from warfarin because of the ease of administration for both the patient and for the physician. But I think cost becomes a big issue, and depending on what healthcare system you're in, that may determine what you do. I want to point out again that as far as any bleeding complications, this is from AFib work, but it just talks about bleeding when you're giving the anticoagulants for AFib. And to look at, there's not much difference between warfarin and the newer oral anticoagulants. So comparing them on bleeding risk, they pretty much, it's a wash, and none is really greater than the other depending on what study that you look at. So what does increase major bleeding risk? If you're on antiplatelet agents, if you have uncontrolled hypertension, again, as I stated earlier, INR is variable, that you're outside the target range. if you have an alcohol issue. These are things that might increase your bleeding risk. So in summary, you need to look at a patient, decide how is their renal function, how is their compliance, can they afford the medication, and decide what is their bleeding risk, and from all that, decide which is the best medication for them. And then we decided earlier that indeed for this patient, we can treat her as an outpatient. So treatment duration, how long do we actually treat the patient for? So her original clot was provoked by travel. You've prescribed rivaroxaban. She's been under your care for 3 months, and she's asked how long should she remain on the medication. So how do we make that decision? So what we have to decide, was this a provoked clot? Do we know why she had that clot? Can we point our finger at a reason? Or is there an unprovoked clot? And we'll talk about the different management workups for each group. So what are provoked clots? Surgery is probably the biggest offender for a provoked clot, with the lowest incidence of having another clot in the future, because there's for sure a specific event that caused this clot to occur. So a provoked clot surgery, you would treat her for only 3 months of anticoagulation. She wouldn't need longer than that. Other things include estrogen therapy, pregnancy, a leg injury, or a flight greater than 8 hours as far as travel history. And for provoked clots, there's a better near-term mortality and long-term limb health. There's very little additional workup you have to do because you pretty much know why they have the clot, and you could stop the anticoagulation after 3 months of therapy. If you stop sooner than 3 months, studies have shown that you can get extension of the clots or get other clots. Also, to digress a second, if you start, let's say, Coumadin without that the heparin overlap, you also can get extension of the clots and more clots. So it's really important that you follow guidelines and stick to the 3 months, stick to using heparin when appropriate before you use the oral anticoagulants. Now, there is some controversy, though, about the significance of some of these risks for provocation of a clot. For example, not everyone, certainly, on a long plane flight gets a clot. Why do a handful of people on flights greater than 8 hours get a clot? One would argue that maybe the reason they got a clot is there is some underlying condition that predisposes them to a clot. So though in the guidelines, greater than 8 hour flight is a provoked clot, in the back of your mind, you might be thinking, but is there some other reason that this person of all people got that clot with a flight? The same might be said with estrogen therapy. We use estrogen therapy all the time. Why do some women get clots and some women not get clots? So you may think in your back of your mind, is there something else going on with that patient? But recommendations say that these are reasons for a provoked clot, and we just need to treat for 3 months. Now, malignancy always bears its ugly head, and what you would do for a patient, just to be sure, would make sure that you've taken a good history and physical, you've gotten just some basic labs, including a CBC, lights, liver panel, just to make sure nothing is rearing its ugly head, and certainly make sure for any patient they've had their proper age-appropriate cancer screens, just to cover your bases that cancer could be a possibility in anyone who gets a clot, even in people with provoked clots. Now, what about unprovoked clots? These are patients that just all of a sudden have a clot and you can't come up with any reason for having that clot. And these are patients who fare poorly with their clots. They tend to be more serious, they're more limb-threatening, more serious PE. They're commonly associated with some kind of underlying condition, and these patients most likely should be worked up to try to figure out what is the reason for their unprovoked clot. And unprovoked clots are more likely, much more likely than provoked clots, to have recurrent clots in the future. So this brings us to thrombophilia testing, and particularly with unprovoked clots. When do you decide to do thrombophilia testing, and when do you not? So thrombophilia testing, certain things to remember. These include acquired and inherited factors. If you decide to test for for the thrombophilias, you must realize that the clot itself can affect many of the lab results. Also, the therapy you're using for the clot can also affect many of the lab results. So it's very important that if you decide to test for thrombophilia, you do it at the right time. And that would really be when the patient is clot-free and no longer on anticoagulants. And I would say that would be after your 3-month mark. About 2 weeks later, they're no longer on anticoagulants, so they no longer have a clot, and they're 2 weeks anticoagulant-free. That would be a good time if you decide that you want to test, that you test. Remember, though, that factor V Leiden and the G20210A prothrombin gene mutation are genetic abnormalities that you can test at any time. Homocysteine level you can test at any time. Everything else that you would look for can be affected by the clot or the medications itself. This is an exhaustive list of all the possibilities that one could test for if somebody has an unprovoked clot. You will not be testing for all of these, but it's just to give you an idea that there are many other things that are very rare that can possibly pop up. If you do testing, what do you want to test for? You do want to test for factor V Leiden and the prothrombin gene mutation. You do want to test for protein C, protein S, and antithrombin 3. You could test for hyperhomocysteine. You want to test for antiphospholipid syndrome. And that's probably about as far as you want to go. A lot of these things on here are much more rare entities, but the ones I just mentioned are what you would really do in your panel looking for thrombophilia. But the real question, despite knowing what to test for and the appropriate time to test for it, is do you actually have to do it? So let's look at this. Are the results of your thrombophilia testing going to influence your intensity of anticoagulation? Well, not at all. You're either shooting for an INR 2 to 3, or you're on one of the newer anticoagulants, and there's nothing to monitor. Will the results influence the duration of therapy? Well, the recommendation now is, if it's a provoked clot, you treat for 3 months. If it's an unprovoked clot, you might look at a few other things we're going to talk about in a few minutes. But if it's unprovoked, you should strongly consider permanent anticoagulation in that patient. And so testing for thrombophilia and knowing somebody has factor V Leiden or one of the others isn't going to matter that much, because it's not going to change your therapy. Your duration of therapy, if it's unprovoked, you're most likely going to continue therapy indefinitely. Perhaps it would influence your decisions for the patient and the family. Possibly, particularly, let's say it's a woman and she's thinking about getting pregnant and she does have an underlying thrombophilia, and that may make the management of her pregnancy a little bit different. If you're just curious, well, a lot of times we're just curious, and these tests are quite expensive, particularly if you do the whole panel. And if you're just doing it out of curiosity, but it's not going to change anything that you do clinically, do you really need to order the tests? Probably most frequently, we just kind of do it without even thinking about it, and it doesn't really help us all that much because it's unprovoked. We're continuing the therapy more than 3 months, and it hasn't changed anything we do with the patient. And often I have seen the tests being done at the inappropriate time. That would be when the patient still has the clot or they're still on anticoagulants. I've had many patients come in, and on their problem list, they have multiple abnormalities listed in their coagulation profile, when indeed those abnormalities were only there because the testing was not done at the appropriate time. Just to talk just a little bit of antiphospholipid syndrome, because this is probably one of the more commons, and you should strongly consider testing for this. This may have more implications than just the clot, and this is the testing that you would do: lupus anticoagulant, anticardiolipin antibody, and the anti-beta-2 GPL. But again, you want to test for this when they're not on the anticoagulants and they don't have the clot, because these can be affected by that. But these are the 3 tests you would order for antiphospholipid antibody. If you want to learn more about thrombophilias, this is the main source. It's very comprehensive about how you should consider thrombophilia testing, when and why. So if you're thinking of testing, certainly, especially if it's a younger person, less than age 45, I would strongly consider antiphospholipid antibody testing. If there's a really strong family history and you think that's going to change the therapy for the patient or change the therapy for a family member, you might consider doing thrombophilia testing. And in selected patients, particularly patients who are thinking of becoming pregnant, you might want to test with thrombophilia testing. But I think really I would recommend against testing, and guidelines are recommending against testing unless you have a really firm reason of how that's going to change what you're going to do for the patient. So you would treat a proximal DVT or PE unprovoked for at least 3 months. You're most likely going to treat indefinitely if it's unprovoked. What would make you not test indefinitely? What would make you more likely to treat indefinitely and maybe not? If you're a male and you have an unprovoked clot, you have a 50 to 75% chance of having another clot. And if you're a male, it's almost a no-brainer. You should receive anticoagulation indefinitely. It's also recommended, if you're trying to risk stratify someone, that a month later, after you've stopped therapy, after that 3-month mark where they shouldn't have a clot anymore, and you check a D-dimer. If the D-dimer is actually high, that may mean they're at higher risk and they should go on anticoagulation. Where would this be important? If it's a man, I wouldn't necessarily check for a D-dimer because they're already at higher risk because they're a male. If it's a female and you're on the fence of treating for an unprovoked DVT, you might consider getting a D-dimer a month later. And if that D-dimer is high, I would push that female into staying with really lifelong anticoagulation. Whereas if the D-dimer is low, maybe you can talk about it and perhaps negotiate waiting and see if a second episode takes place. But certainly if someone has a second DVT or PE, there's no question they need to be on lifelong therapy. That's listed here. If you've had a previous VTE, you have a second one, there's no question. You're really risking your life by not being on lifelong anticoagulation. Other things that if you have poor cardiopulmonary reserve, and you're at low risk for bleeding, if you're at higher risk for bleeding for whatever reason, then you may straddle the fence a little bit. So really, unless you're a woman with no other risk, almost everyone will be indefinitely treated for an unprovoked DVT indefinitely. Remember, test young patients for antiphospholipid syndrome, and again, that D-dimer might be valuable about a month later to risk stratify your patient. A few studies have shown, though, that aspirin actually may help just a tiny bit. So if you have a patient who is very, very reluctant to go on an anticoagulant for whatever reason, they don't want to go on a newer one, they don't want to go on Warfarin, and you just cannot convince them despite the data and their risks, a low-dose aspirin could be an alternative that at least will decrease their risk a little bit, not a lot, but an antiplatelet agent, aspirin, would be better than nothing. And we have some data about that if you're interested. Okay, now we're going to a whole different area, and that's so often the family physicians and internists are asked to do preoperative evaluations on patients who are on anticoagulation, and what do we do with that anticoagulation? So here's Claire again. She's been under your care for 2.5 months, under that 3-month mark. She is still taking her anticoagulant medication as prescribed. She recently had a gallbladder attack, of course, and she's now scheduled to have the gallbladder removed. What do we do with her? So again, we have to look at the balance of what's the risk of her having another clot or extension of the clot she already has versus what's her risk of bleeding with the surgery. So let's look at surgeries / procedures that are high risk versus ones that are low risk. So high risk surgeries include almost any urological surgery. There's going to be a lot of bleeding. Pacemaker surgery isn't going to have a lot of bleeding, but if you do bleed, you're going to get in trouble. If you have large colonic polyps that are being removed because they're in a large stalk, bleeding becomes an issue. Any kind of bowel surgery becomes an issue. Any surgery where there's extensive tissue injury already, so major traumas and so on. Or surgeries where you're talking about small spaces where if any bleeding occurs in that small space, you're really in trouble, like the pericardium, intracerebral or epidural spaces. So these are your high-risk bleeding surgeries. Now, what are low risk? Low risk are really minor dental surgeries, dermatological surgeries, and cataract surgery. I really want to emphasize this. The guidelines say that you can actually have dental procedures, and that includes tooth extractions, root canal, still staying on your oral anticoagulant. All the dentist or the oral surgeon has to do, they need to have some pro-hemostatic agents on board and control any bleeding, but the bleeding is very, very minor, and the risk of stopping the anticoagulant is greater than the bleeding that you can have with minor dental procedures. The same is true with minor dermatological procedures. If you're doing excisional biopsies for basal cell, squamous cell, AK, pre-malignant lesions, again, you can do this while on your anticoagulant. One of the challenges for us as primary care physicians is teaching our consultants with tact. And this is one of those times where you can talk to the dermatologist and the dentist or the ophthalmologist and let them know that really they can stay on their anticoagulant during the procedure that they want to do. And the last thing would be cataract surgery is really pretty much non-vascular surgery, and the bleeding risk is very, 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 very low, and that you can do cataract surgery while on an anticoagulant. Now, certainly when you look at our patient, let's say she actually did need the surgery within that 3-month window, she absolutely needed the surgery. For any of these, you certainly can keep her on the anticoagulant, because if you took her off, her risk is very high for recurrence or extension. Now going back to the other side, not looking at the bleeding, but looking at the risks for the DVT. So what's your high risk period? If you had a recent VTE, that would be within the last 3 months. If you have a known severe thrombophilia, and the thrombophilia is the ones that are considered severe are protein C, proteins S, antithrombin 3, antiphospholipid, and anyone who has multiple abnormalities. Okay, those would be considered severe, and these are people that you want to have off anticoagulants for the shortest period of time, or if possible, certainly if it's recent, make sure that they don't have the procedure until they're out of that 3-month window. Moderate risk is considered the VTE between 3 and 12 months. They have a non-severe thrombophilia, and non-severes are considered mainly those genetic factors, heterozygous factor V Leiden, or the prothalamin gene mutation. Recurrent VTE are actually in the moderate risk category, and if they have an active cancer, it's the moderate risk category. So these are people that you would try to keep them off anticoagulants for the shortest amount of time possible, but they're less risk than the other category. And then low risk patients are people who've had VTEs greater than a year ago. Okay, and those are the patients that you might be able to have a longer period without anticoagulants, or indeed they might not be anticoagulated at all. So for patients on warfarin, looking at the procedure and where they are in the high, moderate, or low risk category for having another clot versus the high risk or low risk category for bleeding, you might be able to get by without any bridging at all. Bridging, of course, for warfarin, you're stopping the warfarin, you have to arrange for the low molecular weight heparin, and there is actually increased bleeding during that period of making this transition in for the 5 days prior. Okay, keeping in mind your stopping the anticoagulation really depends on the half-life. So warfarin, you need to stop it 5 days ahead of time, and that's too long a time to go without an anticoagulation, especially if the patient's in the high risk or moderate risk clotting category. So you do need to do that bridging with the heparin for the 5 days when they're no longer on Coumadin. Now for the other anticoagulants, the newer ones, bridging is really something you don't even need to think about. Their half-life is short enough that you can stop the medication 48 hours ahead of time. It will be out of their system and you're going to be okay, and the idea of bridging becomes superfluous. Now, when do you stop? When do you have to rethink that is depending on the renal function of the patient. If they have decreased renal function and they are on one of the newer anticoagulants, you might have to stop the anticoagulant sooner rather than later, so not 48 hours, but maybe 4 days prior, because they will take a longer time to clear the medication because of the renal function. So the real take-home message here is that many procedures can be performed safely without stopping the anticoagulation. Again, emphasizing dental, derm, and cataract surgery can be done. You can use the guidelines as a resource, as a reference, if the consultant wants to see it in writing. But I think tactfully speaking with your consultant so you don't put your patient at risk for a clot. And certainly in our case that we're talking about here, we would like to see if at all possible we can have the gallbladder surgery after that 3-month window, because she's at high risk to stop the anticoagulant and have surgery during this time period. And since she did have a provoked clot, if everyone was agreeable, I think we could safely stop the anticoagulation at 3 months. And then if it's safe and the surgeon and the patient's okay with it, then do the gallbladder surgery. For patients who require interruption of the anticoagulation, for the newer ones, 28 to 48 hours is sufficient. If you are using low molecular weight heparin, bridging with Warfarin, you would want to give your last dose of heparin the morning beforehand at half a dose if you were using once-a-day heparin. If you're using twice-a-day heparin, you would give your dose the morning beforehand and not give your dose the night before the surgery. So if you're using once-a-day heparin, it's half of the dose the day before the surgery in the morning. And if you're using twice-a-day heparin, you don't give that evening dose the night before the surgery. And there actually is a study being done on this actual topic. It's called the PAUSE study, meaning the perioperative anticoagulation use for surgery evaluation. And hopefully when that study is out, we'll have some more hard data on how to handle anticoagulation with surgery. So we summarize Claire. She had an uncomplicated provoked DVT. She was treated with a NOAC for 3 months. During her treatment, she had her gallbladder surgery removed with no issues. Actually, I would say that we were able to postpone her gallbladder surgery for more than 3 months. Everyone was agreed that 2 more weeks did not matter for the gallbladder surgery. We kept her on her anticoagulation for the 3 months, and then we took her off, and she safely had her surgery. That's such an important point to make, that really, if they're in the high-risk time, unless it's absolutely emergent, try not to do surgery during that first 3-month period. So Claire is no longer taking anticoagulation medications, and she's flying to Barcelona to meet her family for her 50th birthday celebration. Which then brings up another issue. What do you do when people fly and they have a history of DVT? So certainly talk to your patient about perhaps wearing compression stockings while they're in the flight. I would encourage them to get a aisle seat on the flight. I would encourage them to get up and walk around during the flight. They could do leg exercises so they're not just sitting with their legs down during the whole flight. So there are things to do to help mitigate against getting another clot on a flight when you're no longer in anticoagulation. It is not recommended to start anticoagulation for just a short term while they're on a flight or using antiplatelets. It's not recommended to do that, but it's just really behavioral things that might help her so she has a great 50th birthday celebration clot-free in Barcelona. Okay, that ends our talk for now. Here's some of our references. Remind you also about the ME website that your patients can get on and learn more of the details about anticoagulation and DVTs, and they could watch that, and so it'll save you some time in the office with your education. And I think that about concludes what we have. You can go also to our Team Anticoagulation website, and there's just anything you would want to know about anticoagulation is on that website. So we have a lot of the different scales we've talked about, a lot of the reference material. So certainly go there to learn more about anticoagulation. So thank you, and I certainly hope that this has helped you in your understanding of how and when to anticoagulate your patient, a little bit more understanding on the newer anticoagulants, and also what to do around procedures and surgeries.
Thank you, Dr. Dressner, and thanks to all of our watchers and listeners today. Again, there will be a link at the end of this activity. You can click the link, complete an assessment, and ask for your CME certificate. If you'd like more information on this topic, please go to www.teamanticoag.com. Thanks again. Bye.